Hey friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the venous thrombosis, phlebothrombosis and thrombophlebitis. Venous thrombosis is of two types, thrombophlebitis. The endothelium is injured by inflammation. Phlebothrombosis. Here clotting is the primary disturbance. It is more common and dangerous due to the greater risk of pulmonary embolism. Clinical features. It may be silent or undiagnosed, or there may be pain in the cough. Unexplained slight pyrexia may be there. If the lumen of the vein is occluded, there is a dilatation of superficial veins. A slight rise in local temperature of the leg. Edema of the ankle. In extensive iliofemoral thrombosis, the whole lower limb is swollen and the white. If the collateral channels remain patent. If the collaterals are also occluded, the leg is blue, pre-gangrenous condition. In contrast, there may be no signs in the presence of an extensive non-occlusive potentially lethal clot. Pulmonary embolism is frequently the first clinical manifestation of venous thrombosis. Diagnosis. Phlebography, the most certain way of establishing the diagnosis. The veins from the ankle to the inguinal ligament can be demonstrated by ascending lower limb phlebography. Percutaneous iliofemoral phlebography may also be required. The uptake of iodine 125 labeled fibrinogen for early detection of thrombosis is as in post-operative cases and by ultrasound for assessing the potency of deep veins in patients who present with a swollen leg or with pulmonary embolism. Prophylaxis. Stasis is prevented, especially in post-operative cases, especially within 72 hours. Early ambulation should be encouraged after surgery and medical illness. Active exercises should be encouraged or else limb is elevated. An elastic support should be worn if the patient is at risk of thrombosis. If confinement to the bed is unavoidable, the patient should be encouraged to move the lower limb frequently. In hospital, exercises can be organized under supervision of physiotherapist. Faulty posture in the bed should be corrected, tight bandages avoided. Cardiac failure and dehydration should receive attention. The patients at high risk must receive heparin or intravenous dextrose. Treatment. The principles of treatment are to prevent propagation of clot, pulmonary embolism, damage to the valve of the vein, and chronic venous insufficiency. The objectives are best achieved by heparin. The role of oral anticoagulants is to prevent recurrence by long-term treatment. Treatment is started with heparin and continued with warfarin unless there is contraindication like active peptic ulcer or post-operative bleeding surface. Heparin is usually given for 7 to 10 days by intravenous infusion or infusion pump in a dose of 25,000 to 40,000 units daily, controlled by a clotting time or twice or thrice normal. Alternatively, 10,000 units may be given every 6 hours by intravenous injection. If bleeding occurs, it usually stops by withdrawing the heparin. Protamine sulfate 10 to 30 milligrams IV is a specific antidote to heparin, but is rarely required. For long-term treatment, warfarin is preferable. A single dose of 20 to 40 milligrams is given and the prothrombin is measured on the third day. The aim is to 2 to 2.5 times that of the control. The maintenance dose of warfarin is 1 to 10 milligrams daily. The oral anticoagulant should be continued for at least 1 month. If there is a gross swelling of legs, continued for 6 months. The risk of hemorrhage increases if as control is difficult. If there is liver damage, if patient is taking phenylbutazone, salicylates or clofebrate, abrupt withdrawal of phenobarbital is also dangerous as it promotes the breakdown of warfarin. The specific antidote of warfarin overdose is vitamin K, 10 to 20 milligrams IV. Streptokinase treatment. Treatment with streptokinase is preferred for iliofemoral thrombosis. Surgery. Thrombectomy should occasionally be preferred for a recent non-occlusive thrombosis at iliofemoral region. The legs should be elevated to 15 degrees and physiotherapy commenced after 48 hours. Constipation or other straining avoided due to danger of pulmonary embolism in such circumstances. The venous flow is accelerated by support of a tapered elastic hose, but care must be taken to avoid a constricting effect by the hose rolling up. The ambulant women should wear elastic support tights, and for men, below knee elastic hose is best. Permanently after severe thrombosis, to control chronic venous insufficiency. Superficial thrombophlebitis usually responds to an elastic support and phenylbutazone in a dose of 200 milligrams thrice a day for about a week. There may be complicating deep venous thrombosis, particularly if the proximal saphenous vein is involved. In this case, anticoagulants are required. That's all about the venous thrombosis, and in the next video I will discuss about some other disease. Thank you.